You know, hearing loss, we could talk for hours about hearing loss, and you know, there's an entire medical specialty for hearing loss, and there's audiologists, an entire, you know, doctorate specialty for just hearing aids. So it's a very broad subject, and I'm here to kind of talk about some of the implications. But before I talk about those implications, I kind of need to talk about some of the anatomy and kind of briefly how we hear so that it makes sense about those implications. First of all, who has hearing loss? Well, if you kind of look at this pie chart here, you can see about 70% of those with hearing loss are over 45 years of age. The numbers are really irrelevant, but basically a large portion of that pie is basically people who are over 45. So it is somewhat of an age-related condition, and that's because there's natural age-related hearing loss. So briefly, I'm going to talk about the anatomy of the ear and how we actually hear. We're going to talk about some causes of hearing loss, some of which you probably know and some of which you may not. We're going to talk about some symptoms, again, some of which are obvious and some of which may not. And then what are some of the implications of kind of long-standing hearing loss? Briefly, I'll touch base on treatments. That's an entire talk in and of itself, and we'll go from there. So this is a crazy picture with all kinds of lines, and it kind of shows the intricacies of the ear and all the different pieces and how they work together. And this is what I had to study, and this is what I had to memorize, and all the different parts, and this is what I operate on. And so I'm going to kind of break it down into a bit more of a character drawing because I think that's a little bit easier to kind of read. But basically, the anatomy of the ear starts with the outside. We have the auricle or the pinna, which is this portion right here. And that basically works as a funnel to funnel the sound down the ear canal. And the ear canal is not just for Q-tips, it actually has a purpose, okay? It's to push that sound down and concentrate it into a small area right onto a drum called your tympanic membrane or your eardrum. And all those sound waves go down, hopefully without being interrupted, and they move that eardrum in and out very quickly on a microscopic level. When that eardrum goes in and out, the ear bones that I just pointed to transmit that sound into a very small, almost microscopic piston right here. You can just barely see it. And that piston goes in and out thousands of times per second and basically causes what's like a Morse code, like a beep, 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 beep. And your cochlea, which is the purple spiral thing there, basically picks up that Morse code and transmits it via a wire or a nerve to your brain. So we're taking sound from the outside world and we're transmitting it into almost like a Morse code. It goes up the nerve and ultimately goes to the brain. And then your brain is responsible for taking the Morse code, all these beeps and clicks and whatnot, and converting it into what we hear as beautiful sound, okay? This is a labeled human brain. It's the left side. This would correspond to the left ear. And the sound would go to this region right here, which is labeled the auditory cortex. And so there's a whole portion or lining of your brain that's responsible. If we kind of blow that up a little bit, we can see the green area, we can see some labels that say LF and HF, and that's the different frequencies. As you may know, sound has different frequencies. We have low pitch, high pitch, and different pitches correspond to different portions of your brain. So that's kind of a basic gestalt on hearing. Yes?
Only on the left side?
It's on both, but yes. Yep. So back to our drawing here. As you can imagine, if there's a problem during any step of the way here, there could be some causes of hearing loss. There could be a problem any way along the entire pathway that could cause some hearing loss. So as an ENT physician, we kind of break it down into two kind of main categories of hearing. We have what's called conductive hearing loss, and we have sensory neural hearing loss or nerve hearing loss. So essentially, this line right here separates anything to the left of that line. If there's any issues out there, that's going to cause a conductive hearing loss. If there's any issues to the right of that line, that's more of a nerve type hearing loss. Why is that important? A lot of the conductive hearing losses are actually correctable. And so if we can identify that, there's a lot of hearing loss that we may be able to fix. Okay. What are some causes of this conductive hearing loss? Earwax is probably the most common. So I see this every day, at least several patients a day. I just simply clean ears so that people can hear. Okay, and that would plug up this region right here. Okay. Fluid, you can get fluid which develops behind the eardrum in the middle ear. Okay, you've probably all had a cold or flu and your ear kind of gets plugged up and your hearing kind of temporarily drops and your ear feels plugged up. That can be fluid building up in your ear. And then you can get some scarring of all the different structures. So scarring of the eardrum, scarring of the bone, and they don't want to move properly, and that can cause some hearing loss. And on the right side, anything over there would be considered a nerve hearing loss. So what are the causes of sensory neural hearing loss or nerve hearing loss? By far the most common is what we call presbycusis, and this basically is that the cochlea, that little purple kind of spiral structure in your ear, as we age, certain part of it deteriorate. Just like a tire wears its tread, this structure wears down over time. And it starts in the high frequencies. And so you get a symmetric, meaning both ears have a gradual onset of hearing loss that's just related to age. The other cause of nerve hearing loss is acoustic trauma or loud noise exposure. So people who work in factories or shoot a lot of weapons and have chronic loud noise exposure can have a kind of a chronic long-term damage to their ear. For this one, the prevention is vital because there's not much you can do about it once it's there. Oops, and are we freezing here? Let's see. Overall, nerve hearing loss is not curable. And severe nerve hearing loss, with the exception of cochlear implants, there's not much we can do surgically to fix nerve hearing loss. We can only treat it with different things. So how do I, as an ear doctor, how do I determine if someone has a conductive or correctable hearing loss versus a nerve hearing loss? First thing I do is take a look in my office with a otoscopy or an otoscope, kind of magnify the picture of the ear. Oftentimes we can see through the eardrum and see some of those bones of the middle ear. I'll even use a microscope like what you can see in this picture and get a microscopic view of those structures. And then the other two things we do are basically a formalized hearing test. That's something that can be done in my office, but it's also something that's done every day in different audiologists' office. I'm sure several of you have had that done. So a hearing test, you've probably all had it done, and I'm not sure how much you've actually looked at the results of your hearing, but I feel as though I explain this every day, and so why not do it a bit more? Explain briefly what happens when we get a hearing test back. So when we do a hearing test, you sit in the booth and you get a kind of some headphones on, and they do a few clicks or beeps or sounds or tones, and then you kind of push a button, and they kind of gauge where your hearing is for different tones. So for a typical audiogram, it's done from a low pitch to a high pitch. We measure that in hertz. So between 250 and 8,000 hertz. 250 hertz would be like a low foghorn, really low bass sound. 8,000 hertz would be like birds chirping a mile away. It's very, very high, okay? And so pitch is labeled on the top of this graph from left to right. So left is low pitch and right is high pitch. And in the middle, between 1 and 2,000, in that range is where speech is. On the left side of the graph, you can see 0, 10, 20, 30, 40. This is decibels. Decibels is the measure that we use to measure how loud a sound is. It's not a perfect translation, but I break it down into percent hearing loss. So if you get to 30, 40, 50, 60 decibels, it's similar to 40, 50% hearing loss, okay? And ones with X. The circles or the red one is for the right ear, and the X's and the blue one is for the left ear. So you can see that this audiogram is near the top, between 0 and 10 decibels, and it's fairly symmetric. There's a black line right here at 20, and anything below 25 decibels would be considered hearing loss. So anything below 25 decibels is considered normal hearing. I'm talking over 25 decibels right now. Okay? So this is kind of it broken down. As you can see, there'll be different tones on the graph, in different parts, and where it is on the graph will tell us how significant the hearing loss is. So as they drop down the chart, you go from mild, moderate, to severe, to even profound hearing loss. And these can be different between frequencies. You can have low frequencies in the normal range and high frequencies in the moderately severe range. Okay? You can even have the opposite. So this is a typical hearing test. It's not done in color, but the circles are the red ear and the X's are the left ear, so it's a basically perfectly symmetric hearing pattern. But you can see that in the low frequencies, they have normal hearing. As you get into the mid frequencies around speech, they start to drop. And then in the very high frequencies, they have moderately severe hearing loss. And this would be a typical hearing pattern for someone with presbycusis or age-related hearing loss. Another pattern is noise-induced hearing loss. So you can see at the 3,000 to 4,000 hertz range, there's a little kind of a dip, a little cavitation. That's a bit more indicative of someone who's had long-standing noise exposure. Now, oftentimes I don't get the perfect graph from each one because they typically overlap. A lot of people can have age-related hearing loss and noise-induced hearing loss, and so sometimes it's my job to kind of try to parse out the two, and sometimes there's a mix. But these are kind of the essence of what you'll see on a typical hearing test. So what are some of the first symptoms or symptoms at all of hearing loss? Well, the first one that you might see is that you struggle to understand women's and children's voice. Now, why would you struggle to understand women and children rather than men? And that actually makes sense because the pitch of children and women is higher, and most people have a high frequency hearing loss. So the first thing that they're going to notice is that they may miss higher pitched voices such as children and women. So I see it all the time. I get a husband and wife that come into my office, and the wife says he can't hear, and he says she can't talk loud enough. I hear fine. And I always try to stay in the middle, so I take a look at their hearing loss and I say, he's technically got some normal hearing, but in the range where you're speaking, he has some hearing loss, so you do need to speak louder in order for him to hear it. And I usually kind of play that middle road a little bit. But that's why you can have some issues there. Birds chirping are another high frequency. All right, so birds chirping can be something that people miss and they don't realize it. Story is my grandfather a few years ago, I had been pestering him to get hearing aids, and he refused and refused. And he finally got hearing aids, and he called me because he was down in Florida, and he told me for about 5 minutes all the sounds that he had never heard. And so, he had said, did you know that when you walk, if you don't pick up your feet, it scuffs and makes noise? And, did you know when you take a comb and put it through your hair that there's noise with the comb going through your hair? Like all these things that I didn't know existed, but he just learned for the first time in quite a while. So there's some things you may not even recognize you're missing because it's so gradual. We rely on having all of our hearing be the same, and so if there's different frequencies that are lost, one of the things we'll see is your ability to parse out understanding between certain words. And so if someone has normal low frequency but abnormal high frequency, they may have some problems in background noise and certain letters because we rely on all those frequencies to morph together in order to hear those types of things. So not being able to understand certain words and having difficult times during enunciation is another thing that you may notice. Okay. So what are the implications of hearing loss? The biggest one that a lot of people don't recognize, and it's recently come out in the literature over the past few years, is that there's a really strong link between hearing loss and dementia. And a lot of people aren't aware of this. Basically, it's been held true, the old adage, if you don't use it, you lose it. And so on average, seniors or those with hearing loss will experience a reduced cognitive function, so their memory and their mental performance will age 3.2 years faster than the average person with normal hearing. Okay? If you're not stimulating the brain, your brain doesn't use it, so you lose it. Hearing impaired seniors or those with hearing impairment experience thinking and memory problems 30 to 40% faster than their normal hearing counterparts. Older adults with a hearing disability may lose over a cubic centimeter of brain tissue annually beyond normal shrinkage, and I'll go over that in just a second, what that means. Those with hearing loss are 2, 3, or nearly 5 times as likely to develop dementia, depending on how severe their hearing loss is. So back to the picture of the brain here. You can see all these undulations and folds in the top of the brain, and we rely on those to be nice and plump. And as we age, some of those shrink a little bit, and that's normal, but in dementia, it shrinks faster. So the volume of your brain shrinks faster because you don't use it. It's just like if you don't use your muscles, you start to lose your muscles. If the sound is not being transmitted all the way up to the brain because you have hearing loss, then your brain can, in some essences, have some minor kind of dementia, or what we call atrophy or shrinkage. I just showed you one area of the brain, okay? There's obviously thousands of different areas that respond to thousands of different things, and that's why the more you stimulate your brain in different ways, the better off you will be. Hearing is just one part of that. So playing a musical instrument would have a lot of risk reduction in terms of using different mechanics within your arm and having a lot of mentation or thinking. But as long as you can hear the sound, then there's no reason that shouldn't have any negative effect. So how do we treat hearing loss? Yes?
If you are hearing impaired to a fairly large degree and you sign a lot, does signing will that eliminate a little bit of dementia, or has that been plugged into your...
Get clear that, it's not to say that not hearing causes dementia. I want to think about it as one of many things that contribute to the risk of dementia. And so, I can't answer that question, 100%, but certainly, communicating and staying and stimulating your brain would have benefits in one avenue. But certainly not stimulating it may have others. Now, when people are born and they can't hear, their brain will actually overtake those hearing centers in the form of different centers that may make more use, like visual centers. And so that would be a different scenario because they were born with it or whatnot. So, very good question. So the treatment of hearing loss. Hearing aids is, obviously you can't talk about hearing loss without talking about hearing aids. They've obviously come a long way. I'm sure some of you have hearing aids. I'm sure some of you have used them or at least know someone who's used them. I'm sure there's been some good experiences. I'm sure there's been some bad experiences. There's a lot of times where people don't wear hearing aids because of the cosmetic look and the association that they have with, different feelings behind them. But nowadays, they make hearing aids that are virtually invisible. I will say once or twice a day, I go to look in someone's ear, and right as I'm going to look in their ear, I say, "Oh, can you take your hearing aid out?" Because I just realized I had one in. So, that's how great nowadays these can actually be. Depending on your hearing loss, depends on which type of hearing aid you can get, but that's a whole nother talk. My brief plug about hearing aids is they're the most effective treatment for most patients, okay? And the most important thing is to make sure you match a hearing aid with your hearing pattern, and that's where an audiologist has several years of schooling and several years of practice to help match that for you and recommend which one would be the best one for you specifically. But if you get what I call a garbage hearing aid, it sends garbage signal into your ear and you get garbage out. And so it's really important that you get a hearing aid. Now, they can be expensive, so there's a lot of constraints with hearing aids, and sometimes something is better than nothing, but in general, we want to try to get the best hearing aid that matches your hearing pattern. Some people who have such severe nerve hearing loss may be candidates for cochlear implantation. And that's a whole nother topic, but that's a surgical procedure. You've probably seen those on TV or maybe even know someone who's had a cochlear implant. But that's a surgical procedure where they put a wire in that cochlea, that purple spiral organ. under anesthesia, and that stimulates the nerve directly, so it bypasses a lot of your ear. There's very, very select candidacy for that. You have to be almost profoundly deaf. But tinnitus is defined as this sensation of a sound in the absence of external sounds. What does that mean? That means you're the only person that can hear it, and it's strictly unique to you. No one else can hear it. So it's usually a high-pitched buzzing, ringing, beeping, roaring, whooshing sound. I won't be able to hear it, only you'll be able to hear it. That does not mean it's not real and it's only in your head, but it's something that is very unique. If I could develop a cure for tinnitus or tinnitus, I would probably be a very wealthy man. But as of right now, there really is no cure for it, which makes it a difficult thing to treat. But the prevalence is really high, and it's associated with hearing loss. It increases with age. 80% of people with ringing in their ears, and it can be very severe, won't seek help. 6 to 8% of people will have it very severe, and 40% of patients can actually develop depression if it's so severe, so it can be quite significant. This can vary between barely noticeable or intermittently noticeable to absolutely deafening and kind of mind-boggling. Very little is understood about the cause or a cure. It's about 10 to 15% of the population have tinnitus. You might have some loud noise exposure, and maybe you guys have kind of had this periodically with a cold, but everybody at some point in time has probably had a time where they heard some kind of ringing briefly in their ears, and sometimes it's just temporary and sometimes it's permanent. Typically it's only permanent if you have long-standing hearing loss. And you know, noise exposure is another thing that's definitely linked to tinnitus. So hearing aids are central to the management of tinnitus. It's probably the best thing we have for managing tinnitus or ringing in your ears. Tinnitus is certainly caused from high-frequency hearing loss. What I tell my patients is, if you have any high-frequency hearing loss, go back to the diagram with at the very end you have that little tail that drops off in the high frequencies. If you have any high-frequency hearing loss, I tell people your body unfortunately makes up that sound in the form of ringing. And if you treat it with a hearing aid, you treat your hearing loss with a hearing aid, sometimes it changes the perceptions or the input going into your brain and can help reduce the tinnitus or that ringing in your ear. And so it's not always a cure, but it can certainly help. Okay. You probably won't be able to read this. This is more just for illustrative effect, but this is a direct snapshot from my guidelines that I use to recommend what to do with tinnitus and how to treat it. And essentially you'll see that there's basically two things that I'm supposed to recommend for tinnitus. They get evaluated for a hearing aid and use a hearing aid if they can benefit from it, and therapy to deal with it if it's really bad. That's essentially the only treatments for tinnitus. Everything else beyond that, they typically recommend we don't do. And so there's a lot of supplements and things that, you know, may be effective for one person and not for the other. But generally speaking, it's a very, you know, unfortunate outcome of hearing loss. It's very difficult to treat and makes my job somewhat more difficult on a day-to-day basis. There are some noise generators that you can use. And so having background noise like an air purifier or a fan, you know, or they actually have little noise generators that can go in your ear, and they emit a constant sound to try to kind of mask out that tinnitus or that buzzing in your ear, and those can be effective to help people deal with them as well. And an audiologist would work with you for that. So this brings me to the end of my talk, and I kind of have just a couple of slides on what we just talked about briefly, but the main thing I want to get across for you to know and to share to others is protect your hearing. It's not getting any better. That's what I tell my patients, even young patients. You know, there's those ear pods that people wear nowadays, and the headphones and the rock concerts and different things. You know, every time you use loud noise, you can cause damage. And when that happens, it's never really going to get better. And so I like to equate it to it's like tread on a tire. Once you start to wear it down, it's never going to come back, and you can't just change the tire. And so you need to protect it and treat it well. And so if you're around loud noises, protecting what you got is imperative. That becomes even more important as someone develops hearing loss, because if they develop hearing loss and then they're around loud noises and it drops even more, it can get into the realm of being critical where they can't function because of the significant hearing loss. So if you have, or if someone else thinks you have hearing loss, the first thing that you should do is get evaluated to make sure that there's no correctable causes of the hearing loss. And so whether that's your primary doctor or an ear doctor like myself, having somebody look in your ears, making sure that there's no obvious wax impaction in there, making sure that there's no obvious fluid in there, things that could be correctable and easy to kind of fix and, improve your hearing. I have a lot of patients that have hearing aids and their hearing aids suddenly don't work. We take a look in their ears and then they're just jam-packed with wax. We take the wax out and miraculously their hearing aids work again. And so that's something to think about. If you have hearing loss, I really recommend you treat it with hearing aids. The moment I cross that threshold where I start missing things with my hearing, I'm going to get hearing aids. And if that's, in 5 years, I'll do it. I don't care. I would get hearing aids as soon as it would make sense. And so at any age, I think nowadays the cosmetic appeal of them is pretty minimal. I think that there's a lot of literature, like we discussed, that treating your hearing is just really important.
I just had a question. Is it true that the earlier you get hearing aids when you need them, they're easier to deal with?
Yes, to some degree. So I didn't show you on that hearing test that I showed you briefly. I didn't want to get into it too much, but there's another test that we do that maybe you might not even recognize, that we ask you to repeat certain words when you're doing a hearing test. And that's when we're actually testing your brain's understanding. And so what we do is we look at your hearing test, we see where your hearing level is. We amplify it 40 decibels louder than that. So we know you can hear at 40 decibels. We amplify it to 80 decibels, so we know you should be able to hear it because it's louder than it ever needs to be. And then we tell you words and have you repeat those words, and then we get a percentage of how many of those words you got correct. If that number starts to drop, that's a sign that the brain hearing center is starting to drop, and the most common cause of that is it not being stimulated. And so the sooner you get hearing aids, the more likely your brain's going to be stimulated. What tends to happen is people don't realize their brain's not getting stimulated. They don't realize they're not getting the words. And so if they wait 10, 15 years with hearing loss, and then they go get a hearing test, they realize that they're only getting 60% of words correct because they haven't been stimulating the brain. Great question. There's generally no cure for tinnitus or ringing in the ear, but treating hearing loss with hearing aids can certainly be helpful. Okay? If you don't stimulate your brain's hearing center, you can lose some of it and increase your chances of dementia. It's not a one-to-one cause. I don't want anyone to leave here saying, hearing loss causes dementia, but it's one of those things that is fairly easy to do to combat it. So in summary, if you have hearing loss, treat it with hearing aids, all right? So that's my talk. I'm open for questions. I feel as though there'll probably be a few questions. I'm happy to talk about anything from wax, cochlear implants, all whatever you have to throw at me.
Concussion protocol, that involves the hearing. Does your hearing get better after? You see that in sports a lot with young people. Mm-hmm. And they clear them for a concussion.
Yeah. So a concussion is, the question was, if you have a concussion, can it affect your hearing? And then if it does, can it get better? Correct? Concussion is a word that we throw out for just an injury to the brain. And so as you can imagine, there could be different portions of the brain that get injured. If the concussion or injury to the brain is in the portion of hearing or involves the actual inner part of the ear, we can get what we call a labyrinthine concussion. And that's the term for basically a concussion that does affect the hearing. How severe it was and the amount of time is really questionable as to how much it will come back. But we do certainly see that. I'll see people that get dizzy from it because they hit their ear balance center. And so I would say that I wouldn't counsel somebody to say that it's never coming back. but I wouldn't counsel somebody to say that it's definitely coming back. It's very case dependent, and we would follow them with repeat hearing tests. Good question. Yes?
Could you explain about Bluetooth, the new methods of hearing?
Yes. So, first of all, a disclaimer, I'm not an audiologist. So, my job is to find out whether somebody's a candidate for a hearing aid and correct their hearing if I can through surgery or different procedures. And then I rely on the audiologist to recommend it. But Bluetooth is just a way to transmit sounds wirelessly. And so there's a lot of hearing aids that have technology where they can transmit the sounds from different things directly to the hearing aid. So a lot of times people may have difficulty on the phone because, as you can imagine, the sound coming out of the phone may not get amplified through the hearing aid. So they have different means to send the signal from the phone directly to your hearing aid. And that's kind of the essence of Bluetooth. So at times where you may have difficulty your hearing aid picking something up, you have Bluetooth wirelessly admit that to the hearing aid, and that's strictly hearing aid dependent. But great question. Yes?
If you're on the cusp of a hearing issue and you see ahead and get the hearing aid, is there any complication as far as your brain becoming lazier?
Typically, it's a great question. Typically, they're adjusted to match your hearing. And so if you're just on the cusp, the loudness of the hearing aid wouldn't likely get to levels that would cause hearing damage. So there's not typically any long-term consequence to starting early, so to say, because typically your hearing loss isn't severe enough to have it be so loud. What I typically tell people that are on the cusp of hearing is, that you may benefit from one. Well, first I figure out where they're having problems and try to gauge whether I think they'll benefit or not. But I always encourage them to go with an audiologist or go with a dealer of hearing aids where they can do a trial for 30 days or at least return it if it doesn't work. Because there is a point in time where your hearing loss may not be severe enough that you really benefit from the hearing aids quite yet, and you may have to wait a little bit, and it's hard to tell where that is for everyone. It's different. And so I think it's important to make sure you go with a facility that has an opportunity to return it if it's not working. One of the things that I'll be able to tell on a hearing test is your percent word understanding. If I see somebody's on the cusp of hearing loss and whether they would benefit from a hearing aid, and they're getting 100% of the words correct, meaning their brain's still working well, I'll tell them, hey, you could probably afford to wait a year or two. If I see that they're already starting to drop some of that word recognition, I'll probably push them a little harder and say, hey, there's already some signs that you're missing some words. You may be somebody that may benefit from jumping a little bit earlier. That's typically the way that I approach it.
Missing consonants occasionally.
Mm-hmm.
Would that be jumping premature?
That would be, it depends on your hearing loss pattern, but it wouldn't necessarily be jumping, but you may be on the cusp of it not providing a significant benefit. And if it doesn't provide a significant benefit, your hearing aids don't do you any good in the top dresser drawer. So I always tell people, try them out, and if you don't like it for that period of time, return them, wait a little bit. At some point you will certainly get a benefit from them. And as long as you're being regularly followed, either with an audiologist or a physician like myself, that will typically catch it before it really becomes a problem. Yes?
Suppose that you already are wearing hearing aids and you've worn them for a while and you have an audiologist. What would be the criteria? How would you know that you ought to consult a medical doctor such as yourself?
So audiologists have, when they test your hearing, there's a lot of hearing patterns that they'll pick up. And a lot of times if they see that there's a correctable type hearing loss, they typically won't sell you or recommend hearing aids until you've been evaluated by an ENT doctor like myself. So at least once or twice a week I get referrals for a hearing aid clearance. And so I evaluate their ears and we determine whether there's a surgical correction that can be made. The last thing we want to do is have something easy to fix and someone get buy a $5,000 hearing aid that they may not have even needed. And so the audiologists around here, all the ones that I've worked with, have been phenomenal. I get plenty of consults regarding that. And so I would say that typically the audiologist will be able to tell, and they can kind of cue you. And I think that there's no problem with asking the audiologist directly, hey, do you think there's anything in my hearing that is easily fixable, or do you think I have problems with wax? So oftentimes audiologists will look in the ear and see if there's a big wax problem. And so I don't think that there's any harm in asking your audiologist kind of point blank, and I'm sure they'll give you a pretty honest answer. Kind of a couple questions. The first question was, son with starting to speak louder, is that a sign of potential hearing loss like you suspect? It typically can be. And if he's 52, I don't think there's any reason to not recommend that he get a hearing test. It's simple, quick, and that will tell you right then and there whether he has hearing loss, but that's certainly a sign. Some people talk loud. I see patients every day. I get in the habit of seeing really poor hearing, so I start talking loud, and then every once in a while I get the 98-year-old woman that sits down in my chair and lets me finish my conversation for 2 minutes and then says, "Why are you yelling at me?" So it's definitely a habit that I get into, so it's not always indicative, but yes, absolutely. So what you're getting at, the second question was, she's watching the TV, and at certain times you hear it crystal clear, and certain times you just miss things, but the volume's not really changing. What's going on? As I pointed out before, when you have that high frequency hearing loss, there's probably not a lot of those high frequencies on the TV that you're missing, because usually it's speech that you're trying to hear. But what's a little bit complicated is that we do rely on those high frequencies to help filter out background noise. So the best thing that I can kind of equate that to is you're going out to dinner, everyone's talking in the background, someone's sitting right in front of you, they're talking at a level where you know you can hear them, but you can't hear them. That's because your ability to drown out that background noise becomes very difficult. The TV problem is a difficult problem. They do have some devices in terms of Bluetooth that you can use on TVs that go directly to your hearing aids. They even have muffs that you can wear, hearing headsets that program into your TV, so that if Mrs. Smith has really poor hearing, she needs to wear them, but Mr. Smith has great hearing and doesn't want to have the TV up to 150, you can have a little bit of a way. But typically the only way to kind of combat that is to just augment the hearing, and that's a very difficult thing. That background noise and understanding speech and background noise is a very difficult thing to treat, and that's something that we always continue to struggle with. The question was, if you don't think you have hearing loss at this point in time, would it make sense to obtain a hearing test to get a baseline? I would say that in the setting of no loud noise exposure, probably not. When you feel like you're missing things, or maybe part of a routine physical, that would be the time to do the hearing test. If you work in a loud environment and there's things that could cause your hearing to drop, via loud noise, then having a baseline is helpful, because it helps us determine whether or not those outside things are impacting your hearing. So there's certain medications that can impact hearing, specifically like chemotherapy. And so we'll have patients that will come in, we'll test their hearing, and then they'll get chemotherapy and then watch to see if it drops. And so in essence, I probably wouldn't worry about getting a baseline unless you're exposed to things or around things that you think will significantly drop your hearing. I will say that there is often times that people don't think they have hearing loss, but they do. And so, if you're at all wavering, then it can't hurt to just get one. If you don't feel like you have any at all and you're not wavering, I don't think it's a problem to wait. But if other people are telling you have hearing loss, that can be a sign. So, any other questions? Yes?
What's the usual cost of this initial hearing test?
That's a darn good question, and I do not know. But I do know that it's typically covered. And so I know Medicare covers it, and so typically it's not an issue for my patients. One of the things that's unfortunate about me and my job is I don't have access to all the finances, because there's so many different things that I do. That's for good reason and for bad reason, but unfortunately I don't know, because it's dependent on insurance and whatnot, but it is almost always covered. I think the best way, the way I typically answer that, oh yes, the question was, there's so many different audiologists, so many different hearing aid companies, they have different gimmicks and things to get you to buy their product. How do I know which one to go with, was the question. It's a great question. I tell people it's like buying a car. So everyone has the car that they like the best. Everyone has a car that fits them the best. And everyone has a different opinion. Generally speaking, there's good cars in every car dealership and there's bad cars in every car dealership. And so the only way that you can pick out a good car is to shop around, and there's absolutely no problem with shopping around for hearing aids. So we have an audiologist in my office that tests my patient's hearing, and if they're a candidate for hearing aids, she'll usually give them their card. I see the patient right after, I go over their hearing test with them. I say, hey, my audiologist is great. If you want to follow up with her to talk about hearing aids, by all means do it. But I'm going to give you a copy of your hearing test. You bring it to any audiologist you want to go to, shop around, you can find the best price, there's no harm, no foul. So I would not have any hesitations with getting a couple of different opinions with different audiologists to see which one kind of works you the best. And the other thing is to make sure you get a hearing aid that you have the opportunity to return if you don't like it. But there's kind of a couple different gimmicks with hearing aids. One is, it's not really gimmicks, but a couple different ways to do them. And what I see is it's a high upfront cost to the hearing aid, and then all issues with the hearing aid thereafter are covered. And then there's a low upfront cost to the hearing aid, and all issues thereafter are not covered. And so that's dependent on what you think. I would say if you have significant hearing loss or moderate to severe hearing loss, you're probably going to be needing to get that tuned and get some kind of chronic follow-up in regards to that. And so I would definitely encourage people to go with one where they can see their audiologist frequently without getting charged. If your hearing loss is borderline or mild, you try the hearing aids, they work great, you're probably not going to need to have them tweaked or updated very often. So that's kind of the cutoff there. No, absolutely not. I personally wouldn't feel bad. I tell my patients to, that, and I say it right in front of my audiologist who, makes their living off, testing hearing. You can get a copy of your hearing test. That's the part that typically they bill. So when you get your hearing test, oftentimes just ask for a copy of it, and that way you can kind of bring it different places, and then they may not necessarily have to retest you. There is some variability between audiologists, and one audiologist might get this level and one might get this level. So they may, prior to fitting you in their hearing aid, they may insist on just testing your hearing so they can optimize it. I wouldn't be surprised by that. But in a general consultation about which kind of hearing aids would I benefit from, if you have a copy of your hearing test, they can at least give you a rough idea. And then once you got to the period of where you're actually talking about the hearing aids, then they may need to retest you. But that's kind of a whole other topic. So all you need, you don't technically need to see an ear, nose, and throat physician. That's how I make my living, obviously, but you do not necessarily need to see me prior to getting a hearing aid. It does happen that way just because that's how some people feel comfortable, but primary care doctors can order hearing tests and then start the process. And you can go into an audiologist and kind of start the process that way. What may happen sometimes is you may have something like we discussed that is a barrier to recommending a hearing aid. At that point in time, they may recommend that you see me prior to getting the hearing aid. So the question was, if you go to an audiologist and they recommend hearing aid X, how do you know they're not upcharging you? Or how do you know that that's better than the one down the street? Correct? Yeah. So I'm not an expert on hearing aids. Like I said, that's why we employ our audiology counterparts. But in my history and my research, what I understand is a lot of the components are made by similar companies. So even though the outside and they're different, from place to place to place, a lot of times the components are made by one of two companies, and then they're just kind of packaged together. And so I would generally trust the audiologist about the one that they recommend. I do see it happen, Sure, are there some audiologists out there that may be overcharged? There probably are. I haven't seen any since I've been here that have, meandered down that pathway. I would say generally the hearing aid that they recommend is the one that they think is going to give you the best benefit based off your hearing test. Because hearing aids are like cars, you need different ones for different things. And if somebody wants to be able to tow around stuff for their farm, they wouldn't buy a Toyota Prius. And the same thing can happen for hearing aids. And so you do have some patients with pretty significant hearing loss where they need certain types of hearing aids, but patients insist on getting the cheaper one, the one that the audiologist didn't recommend, and then they don't have good results with it. And so I would say that, it would be not unreasonable to ask if you could try one and see, but I suspect that generally speaking, the one they recommend is out of good faith and the one that's typically recommended. I do see often people have underpowered hearing aids. I wouldn't say often, but occasionally I see people that have underpowered hearing aids for what they probably need. But sometimes that's a financial issue. And so that's obviously a whole different topic of conversation too.
So listen to your audiologist.
Yeah, so listen to your audiologist and then work with the constraints that you have financially and get a second opinion if you want to talk about other ones, and just make sure you can do a trial. Yes, there is, but it's very strict criteria, and the audiologists know it better than me. I unfortunately don't know the strict criteria for that, but there is, depending on your age, your insurance, your job, whether or not it disables you or not, has some different implications on what you can get. Sometimes they'll approve one, but they won't approve two. And so, that I would probably speak with an audiologist. They're going to know more than me for that, for sure. The question was, there's, different types of hearing aids, ones that go behind the ear, ones that go in the ear, ones that are molded to your ear. You've probably seen different commercials or seen people have different hearing aids. There's some variability between them, and sometimes, yes, you can jump between different styles, but oftentimes it's limited by your hearing pattern. Depending on the frequencies that you have that are effective or that are affected by hearing loss will help decide the type of hearing aid that you may tolerate. For example, if you have significant hearing loss, you'll typically need those fully molded hearing aids so that they don't allow any other sound except for the sound from the actual hearing aid, because if sound can get past the hearing aid and your hearing aid's amplifying it really loud, you can easily get down a feedback loop, just like you get into a speaker between two microphones and it starts to amplify. The same thing can happen. So there reaches a point where you amplify sound enough that basically you can get some significant feedback, and so it depends on how loud they have to amplify the sound in different frequencies. The difference between how noticeable it is and how unnoticeable it is also dependent on that factor, but it's also, that can be dependent on price and just different recommendations. And so you would definitely want to talk with your audiologist about whether there's any alternatives that you can do. But sometimes the amount of gain that somebody needs or amplification that they need is substantial enough that they can really only tolerate a certain type of hearing aid. So I generally would trust your audiologist.
Can you share with us some of the words you ask people to repeat? Or is that a secret?
Yeah, no, it's not a secret. So the audiologists actually do it. But we start by generally trying to understand, we start with easy words. Now you may think, what's an easy word versus a hard word? And basically an easy word would be something that has two very clear syllables, like baseball. All right, it's much easier to hear baseball than pizza.
You don't want us to repeat it.
Yeah, so we use different ones to first capture where we know your hearing is, and then we use the harder ones to actually test you. And so it's things, they're typically one syllable, okay, or shorter words, and it varies on audiologists. They have their own little list. Interestingly, the testing for cochlear implantation is done in background noise. So when they test someone for cochlear implant, you're hearing the words, and then they have like a full, restaurant sound behind you. And I actually did it myself, and I struggled to get it. I mean, it's very, very difficult.